Okay, dear colleague, ladies and gentlemen, I'm sorry we are about a little late because of Dr. Nghi. We are late today. He takes us to a very good lunch today. So today I would like to introduce Dr. Richart Child. It's the first time Dr. Child came to our country. Dr. Child is a real American of the U.S. Army. And Dr. Child now is a clinical director of NIH. He has so many things I cannot remember. But I think that I remember only two things. At first, Dr. Child intended to be fellowship in cardiology, but after that, Dr. Child would like to study about immunology and hematology. And now in the role of research, clinical research in NIH, Dr. Child have two talks to us today. The first talk about history church in 30 minutes about research. And the second 30 minutes, Dr. Child explained to us about his role as a clinical director of research in NIH. I would like to introduce Dr. Child, colleague.
Thank you, Dr. Vin, and it's a pleasure to be here today with everybody, and I appreciate what gracious hosts Dr. Vin and his team has been treating me very well to two outstanding meals, and I apologize for being late, but the lunch I just had was probably the best meal I've ever had in my life. So it was absolutely delicious. And as Dr. Vin said, I have two parts that I want to discuss today. First is my research, why I came to the NIH, and the work that I've done in tumor immunology. And then the second part is my role as clinical director at the National Heart, Lung, and Blood Institute, where I have oversight and direct the entire clinical research portfolio for all heart, lung, and blood research conducted at the NIH. And Dr. Mai Lee Win is one of our cardiologists who worked with Dr. Vin here in the past and was the one that established the connection when I told her that I was interested in exploring the possibility of exporting research that we do at NIH in heart, lung, and blood diseases to Vietnam in the context of 2 or maybe 3 center types of studies. And that's how we came into contact with each other, and we talked about the possibility of bringing, some very novel, cutting-edge research that we do at the NIH to Ta Nan Hospital. So in the end, I would like to explore the possibility of us establishing perhaps an MOU and some collaborations in that regard so that we could explore different research areas that would be of interest to the doctors that are in this hospital. We have a very large focus on cardiovascular imaging, and I've done pioneering work over the last 25 years in CMR and continue to do that research. And we also have research that's being done in looking at social determinants of cardiovascular disease and health inequities, and looking at the impact of things like urbanization on cardiovascular risk. So I think there's some opportunities to do some collaborative research in those areas as well. So I'll start with the first part of my talk, which is optimizing T and NK cell-based immunotherapy for cancer, and also exploring novel allogeneic stem cell transplant regimens for patients with aplastic anemia. And then the second part will be opportunities for collaborative research in heart, lung, and blood diseases between Ta Nan General Hospital and the National Institutes of Health. So I've been a physician scientist at the NIH now for slightly more than 23 years. I started as a tenure track investigator, got tenure, and then in 2013 was given the role of clinical director for the NHLBI, I'm also active duty in the service, the United States Public Health Service, as you heard before, and I'm a Rear Admiral and have been involved in a number of public health emergency responses across the U.S. Over the last 27 years, including being involved in going to Africa and taking care of patients with Ebola, helping the federal government set up an Ebola treatment center over there. And I've also had friends and colleagues here in Vietnam. I've had a close partnership with Dr. Bing Vo, who I trained at the NIH back in the early 2000s in bone marrow transplantation, and continue to work closely with her at NIH BT Hospital in Hanoi. So in my laboratory, I have 3 research goals. The first is to explore T-cell immunotherapy for metastatic kidney cancer. The second is to explore ways to make NK cell immunotherapy work for advanced cancer. And the third is to try to improve transplant outcomes for patients with severe aplastic anemia who fail to respond to conventional ATG immunosuppressive therapy. And I'm going to talk today mostly about number 1, which is developing targeted T-cell based immunotherapy for metastatic kidney cancer. So for those non-oncologists in the audience, kidney cancer is a disease that impacts a significant number of patients. It's the 6th most common cancer in men and the 9th most common cancer in women. The 5-year survivals improved significantly over the last 35 years or so, from around 51% in 1975, now up to about 77% in our conventional era, due to a number of breakthroughs in medical treatment, as well as diagnosing patients at an earlier stage with more advanced imaging technologies. So there's 2 different types of therapies that are utilized for kidney cancer. Targeted therapy going after tyrosine kinase pathways that inhibit angiogenesis, and then more recently immunotherapy protocols designed to boost T cells in patients with kidney cancer, including checkpoint inhibitors that activate T cells in patients and make them recognize their own tumor. This is just a list of treatments that have been developed for kidney cancer over the last 20 years or so. So when I first started doing research in kidney cancer, the only 2 therapies that were utilized were high-dose interleukin-2 and alpha interferon, both of which were not very active with response rates, in most cases less than 10%. But the one interesting thing with IL-2 was that even though most people didn't respond to it, a small percentage of people that would respond would have a complete response and would be cured. So that was really sort of proof of principle that the immune system could cure this tumor, and if there were ways to make that immune system more effective, hopefully that response rate would go over 10%. And that's what attracted me from and took me away from cardiology and put me into the field of tumor immunology. But there's been about 10 medications that have been approved for kidney cancer over the last 20 years, all of which have improved the prognosis in patients with kidney cancer. And the focus now in the last 5 years with kidney cancer has been immune-boosting therapy with checkpoint inhibitors. This is a study that shows progression-free and overall treated with checkpoint inhibitors alone, nivolumab and ipilimumab, versus sunitinib, which is a tyrosine kinase inhibitor, showing improved overall survival with upfront use of checkpoint inhibitors. So immunotherapy is now standard of care upfront for patients with kidney cancer. So my interest in kidney cancer was completely different than just about what anybody was doing when I went into the laboratory, and that was I was interested to see if we completely replace the immune system of patients with kidney cancer, whether we could take a healthy immune system and get it to target the tumor. So we started doing reduced intensity transplants on patients with metastatic kidney cancer in the late 1990s, and that clinical trial established proof of concept that indeed we could get a healthy immune system to target kidney cancer tumors. and in some case completely eradicate metastatic disease. So this is a patient that had literally hundreds of tiny metastatic clear cell kidney cancer tumors that underwent an allo transplant. And after about 3 to 4 months, those tumors regressed and the patient achieved a complete response, also had regression of bone lesions, and remained disease-free more than 20 years after the transplant. So we transplanted 19 patients. 10 of the 19 patients had evidence of tumor regression. 3 patients achieved a complete response. We went on and we published this in New England Journal of Medicine. This was my first experience in research as a fellow, and is the reason that I still do research, because it was so shocking to see, these tumors regressing and to see patients that had, a terminal disease going into remission and being cured. So this is a picture that I took a couple of months ago from one of our patients that we transplanted in 2001 that had metastatic disease to the liver, lungs, and bones, who achieved a complete response. And this is me with that patient 2 months ago. And he actually brought a picture with him, surprised me, of when I was seeing him shortly after I finished my fellowship. And, most people would look at this and say, that's not me, but that is actually me. Before the stress of taking care of oncology patients turned my hair completely gray. But this has been an extremely rewarding experience to have patients go through this type of a procedure and to have long-term benefit. So my research in the lab was to try to figure out what were the exact mechanisms that contributed to tumor regression. And our hypothesis was that some of these patients had disease that was regressing that had no evidence at all of any kind of autoimmunity or graft versus host disease, and that their immune system must be seeing something that's expressed on the tumor that's not expressed on any normal tissues, and that this, whatever these antigens were the target of this, what we call graft versus tumor effect. And that if we could identify those antigens, maybe we could direct the immune system specifically against the tumor and not have to put them through a transplant at all. So that's the area that we focused on, and we've made a lot of accomplishments in identifying what the antigen is for the graft versus tumor effect. And the way that we did that was we took responding patients that had tumor regressing. We collected blood from them. We knew that there were T cells in that blood that were seeing something, and we used those T cells and targeted them against many genes that we took from the patient's tumor to try to figure out what exactly was being recognized. So this is called cDNA expression cloning. It's a technology that's been around for a long time. But we just screened different cDNAs with these T cells until we identified specific cDNAs that were recognized and that encoded for the antigen that was a target for the graft versus tumor effect. Doing this, we identified 2 transcripts that are shown here. That when we sequenced those transcripts, we found that they were derived from a completely novel, previously undescribed human endogenous called a HERV that we named the Child's Takahashi renal cell carcinoma virus. So Child's is myself, Takahashi is Yoshiyuki Takahashi, was my postdoc from Japan in the lab that cloned out and identified this virus. The thing that was interesting was that the viral expression was only in kidney cancer cells. We did not find any expression at all in normal tissues, and we found that it was expressed in most kidney cancer tumors. So this is exactly, if you're looking for a tumor-specific antigen, this is exactly what you want to look for. So we also found that a big part of the envelope of this virus was also expressed in these tumor cells and was not expressed in any normal tissues as well. So what is a human endogenous retrovirus? Many of you have probably never even heard of a human endogenous retrovirus, but basically these are retroviral fossils or remnants that are integrated into our genome from millions of years ago. And what happens is that retroviruses infect humans, and occasionally they'll infect germ cells and then they'll undergo reverse transcription, and they'll get integrated into the germ cell genome, and then they'll be transferred to offspring. But then over thousands and hundreds of thousands of years, these endogenous retroviruses undergo mutations, they undergo methylation, and they basically get silenced, and they're not expressed in any tissues. Roughly, the estimate is about 8% of the human genome is made up of these retroviral remnants. So we're all, in part, we're all walking retroviruses, about 8% of us. So Elena Cherkasova in my lab, who is a PhD, worked hard to try to figure out how is this endogenous retrovirus that's in the genome of each and every one of us but is not expressed in any normal tissues, why is it turned on and why is it expressed in kidney cancer? So she did some very elaborate work, and she was able to show that the von Hippel-Lindau protein, which is usually involved in ubiquitinating different hypoxia-inducible elements in patients with kidney cancer. They have mutations in VHL and don't express VHL. And because they don't express VHL, they overexpress HIF2 alpha, which is hypoxia-inducible transcription factor 2, which will bind to the hypoxic responsive element on the 5' LTR of the virus and will lead to its selective expression in kidney cancer tissues, leading to pieces of the virus being processed in the proteasome and then presented on the surface of the tumor in the context of an HLA molecule. So we went from just describing patients having regression of their tumor to identifying T cells in patients that were able to kill kidney cancer cells in vitro to actually using those T cells therapeutically in the clinic. So this is an example of a T cell clone isolated from a patient that had tumor regression that in vitro kills significant amounts of the patient's tumor. And we cloned out the T cell receptor alpha and beta chains from that T cell, put them into a retroviral vector, and then can use transduce or genetically transform anybody's T cells to express that T cell receptor so that they acquire the ability to kill kidney cancer cells. And this just shows lysis of tumor cells from a number of patients where we take the T cells, put that T cell receptor in, and you can see at baseline there's no killing of the tumor, but these T cells now acquire the ability to recognize and kill the patient's tumor cells. And these green cells are tumor cells, and here you can see those green cells decreasing in number as those genetically modified T cells kill the patient's tumor. So we've gone from proof of concept to showing that the human immune system can kill kidney cancer tumor cells, to identifying a novel antigen in kidney cancer, to now cloning out that T cell receptor that recognizes the antigen, and are now treating patients with their own T cells that have been genetically manipulated to express this T cell receptor. So in this protocol that's ongoing now, we bring patients in with kidney cancer that have the right HLA type, HLA-A11. We collect lymphocytes from them. We transduce them with a virus to express the T cell receptor, and then give them some lymphodepleting chemotherapy so that these T cells will not be competing with cytokines from normal T cells, and then infuse these T cells autologously. We give interleukin-2 to make the T cells expand ex vivo, and then hopefully have the tumor regress. So this study is early on. We've been running it now for a couple of years. It's dose escalating, but we've already started to see evidence that these T cells can make tumors regress. Here, a patient with some metastatic scalp lesions that had significant regression, as well as regression of some lung tumors as well. And this is a person that had failed 6 different lines of prior therapy and had really run out of everything. So, this for us is extremely exciting because it establishes proof of concept that these genetically modified T cells can be used to treat cancer. So our hope is we'll complete this phase 1 study. We've patented that T cell receptor. There's a company called T-Cure that's licensed that T cell receptor, and they are bringing this technology to the clinic in the next year or so in the context of a large phase 2 study. So my second area of interest has been on exploring the ability of NK cells to kill tumor cells. And my laboratory, about half of my laboratory is focused on NK cell-based immunotherapy. I don't have time to go through that kind of work because it's quite extensive, and I end up having to talk to you for several hours. But what we have been able to do is collect NK cells from patients, expand them ex vivo, and then have focused on ways to give these NK cells back so that they'll be able to target and kill the patient's tumor. We've developed methods to make these NK cells proliferate in vivo by modifying receptors on them. We have put the receptor for thrombopoietin or TPO on the surface of NK cells, and we can give patients L-trombopag and make these NK cells proliferate in vivo. We've also looked at trying to figure out how to get these cells to migrate to the tumor. We're very interested in hematologic malignancies like AML and bone marrow-derived tumors like multiple myeloma, and we figured out ways to get them to go to the bone marrow better. And then we have ways that we can also genetically modify these NK cells to make them more cytotoxic to the tumor once they get there. This is just to show you some work that we've done to try to see where do these cells go when they're infused. So these are expanded NK cells from a rhesus macaque, where we have labeled the cells with zirconium-89, which is a PET emitter, and then we can track these NK cells by PET-CT. So you can see here in this monkey, in the first hour or so, after we infuse these NK cells, they're going mostly into the lungs initially, and then they start to come out of the lungs and go into the liver, into the spleen. And then by 48 hours, you can see they're still sitting in the spleen and the liver. We want them to go to the bone marrow because in vitro we know they kill AML cells, but what you don't see the bone marrow lighting up at all. So this was a very important study for us because it showed us that there was a defect in NK cell homing to the bone marrow, and has led to us having a big research focus on trying to reprogram these NK cells to put cytokine receptors on them so that they'll actually land where we want them to land, which is in the bone marrow space. So this is just a little more data on that, and I just wanted to show you that if we do the same experiment, but instead of putting NK cells into the monkey, we put CD34 positive cells into the monkey, you can see a very different homing pattern. So you see that the spine is now, and the pelvis is now lighting up, and that's those CD34 positive cells, hematopoietic progenitor cells, reside in the bone marrow. So they get to the bone marrow, the NK cells don't. So one of the things that we've tried to do is reprogram them with chemokine receptors that are expressed on, to reprogram NK cells with chemokine receptors that are expressed on hematopoietic stem cells so that they'll home better to the bone marrow. And that receptor that we've been utilizing is CXCR4, which is very important for stem cell homing in the bone marrow. And we've been able to modify these NK cells to express CXCR4. The other thing that we've observed is that expanded NK cells upregulate a chemokine receptor called CCR5, and we think that that's why these cells are getting stuck in the liver, because the ligand for CCR5 is expressed in high levels in the liver. So one of our ideas has been, can we put in this chemokine receptor CXCR4 to get them to go to the bone marrow, and can we knock out, using CRISPR, CCR5 so that they won't just be stuck in the liver? So this is just work in the laboratory showing that we can take NK cells that have low-level expression of CXCR4 and that we can mRNA transfect in high levels of CXCR4 expression, that we get them to home to SDF1, which is the chemokine receptor for CXCR4, and that if we take mice where we have labeled NK cells that are wild type, that have not been manipulated, if you look at the non-genetically manipulated mice, in terms of bone marrow homing, you see very little bone marrow homing. But if you take those same mice and put CXCR4 in them, you get great homing into the bone marrow. So we're now moving this technology from mice into into monkeys, and hopefully will in the future be giving genetically modified NK cells with chemokine receptors to patients with AML. And the last thing I wanted to talk about quickly was severe aplastic anemia. So we have a large population of severe aplastic patients that come to the NIH. Dr. Neil Young is the world's foremost authority in severe aplastic anemia. If you've not seen this disease before, basically it's a hematologic disorder that's characterized by bone marrow failure, where the hematopoietic elements that you would normally find in the bone marrow have been replaced by fat. We think of this as an autoimmune disease where the host T cells are attacking the hematopoietic progenitors in the patient, leading to bone marrow aplasia. These patients develop cytopenias. They become platelet transfusion dependent, red cell transfusion dependent, and profoundly neutropenic. And if left untreated, this disease is uniformly fatal. Bone marrow transplantation and immunosuppressive therapy are both effective treatments for aplastic anemia, but about 40% of patients will fail immunosuppressive therapy and need to be salvaged with the bone marrow transplant. But the problem is these patients get heavily transfused with red cells and platelets, and because they're so heavily transfused, they're alloimmunized and they're at increased risk for graft rejection. So my group has focused on trying to develop transplant protocols that will overcome the risk of graft rejection in patients that are heavily transfused and alloimmunized with severe aplastic anemia. So we have a number of different protocols that we're running at the NIH for aplastic patients, and these include protocols where we give HLA-matched grafts from either brothers, sisters, or matched unrelated donors, where we partially T-cell deplete the graft to prevent GVHD. And then we also, for patients that don't have an HLA identical sibling, we have a protocol where we give cord blood cells combined with haplo CD34 positive cells to patients to try to salvage patients that would otherwise die from their disease. We've pioneered this approach of doing what we call a dual stem cell source protocol where we combine cord blood hematopoietic stem cells with haploidentical CD34 enriched cells from a donor to give two graft sources, so that if the cord is rejected, we still have the haplodonor CD34 cells that can engraft. And we also know that these enriched CD34 cells from the haplodonor will engraft much faster than a cord. So instead of having to wait 30 days for neutrophil recovery, you can see neutrophil recovery occurring as fast as 10 days after transplant. This is the regimen that we utilize where we give chemotherapy with Cytoxan and fludarabine and also give horse ATG very early on. We call this the preparative regimen. And then after they get the preparative regimen, we give a little bit of total body irradiation and then give these patients this combined transplant of a single cord blood unit and haplo CD34 cells from a matched relative. And this is data that we just published last year showing that in this population of patients that would have died for sure because they didn't have a transplant option, we were able to salvage the vast majority of these patients with about 87% having long-term disease-free survival, very little graft versus host disease, and very little chronic GVHD. So this regimen has been a big success for patients that don't have a donor, a sibling, or a matched unrelated donor. And now we're working with our colleagues at NIHBT who have just started to do this same transplant approach in Illinois. And then yesterday I had a meeting with some of the doctors at BTH Hospital to talk about the possibility of them exploring this transplant approach as well. So that's the first part of my talk. So now I want to switch over and talk about my role as clinical director in the NHLBI. So we have a number of different branches in the NHLBI that are involved in performing bench to bedside research or translational clinical research. And I've listed those branches here, but we have heard of the Framingham Heart Study is under our section, and Dr. Dan Levy is out there and continues to do work looking for different factors that are associated with cardiovascular disease. We have a sickle cell branch, hematology branch, a translational stem cell biology branch, and then also a cellular and molecular therapies branch that does gene therapy for patients with hematologic malignancies as well as patients with sickle cell anemia. So I put all these branches up here because if there's any area that you're involved in that you may have interest, there may be an opportunity for collaborative research. So in my role as clinical director, we have about 300 staff that are conducting or support clinical research, including 120 staff that their role is to provide support for all of the novel cutting-edge research that's being done. Roughly, we have a $240 million annual research program and have about 220 investigator-initiated clinical trials involving heart, lung, and blood diseases. The research that we do is often derived from the bench, so we call it bench-to-bedside research. It's in many cases first-in-human research, and it's usually high-risk, high-reward research. So in some cases, we're doing things that have never been done before to patients, and these can be risky things, but if they're successful, they can be paradigm shifting and can lead to new therapies. And we've had a number of different therapies that have been developed in my institute that have gone on to become FDA-approved therapies. So in my role as clinical director, I have scientific oversight of all the clinical trials. We provide centralized research support from nurses, patient care coordinators. We have a separate recruitment office for all our clinical trials to make sure that we're accruing patients quickly and that we're reaching out to the right groups to make sure that they're aware of our studies. We have patient advocacy groups that the recruitment office is in contact with. We do advertisements in newspapers and also on radio, and we do targeted recruitments and try to make sure that we have a good diversity in our clinical trials and that we don't have overrepresentation of a particular racial or ethnic group that would lead us to misinterpret our data. So we try to keep our patient population as diverse and reflective of the diversity of the U.S. population. Yesterday, we had a discussion about the importance of clinical data science. We have a whole separate office that's involved in making sure that we have professional data managers who collect the data, do QC on the data, and that it gets into a database and gets to our biostatisticians so they can appropriately analyze and report the data. We also have clinical trial monitoring, so anytime we start a new study, if we wanted to do a study, for instance, here at Town On Hospital, we would have that clinical trial monitoring team come here. They would meet with whoever the site PI would be here, and they would talk about what's needed to be able to do this kind of research, the database, and we call these types of visits site qualification visits, identifying any potential gaps in areas that would need to be built out to be able to do the research. A lot of times, this is making sure that we have the right training, good clinical practice training. Most of the stuff is done online, but making sure that anybody participating in the research has done the good clinical practice training, and that if we're doing a pharmaceutical trial, for instance, meeting with the pharmacy, making sure that they're on board. If it's a placebo-controlled study, making sure that there's a SOP for a determination of whether the patient gets placebo versus active drug, and how the blinding process is set up and things like that. And then we also will do monitoring and audit visits to make sure that there's no problems with compliance. So it takes a village to do clinical research, and this is just an example of all the different groups that are involved in supporting, for instance, a clinical trial. This shows you that we have a whole separate office for research nursing support. We have the Office of Education and Patient Safety. So these folks are training everybody to make sure that whatever the trial outlines is a schedule of events, that everybody's on board so that there's no issues related to trial noncompliance. We have an Office of Biostatistical Research and Data Management. We have Office of Protocol Navigation. These are folks that work with the FDA to make sure that we're doing everything that maximizes patient safety. We have the monitoring office, and then we have the patient recruitment office, and then we have all the branches that actually are involved in conducting the research. So, this kind of investment for us, even for our small program, is about $25 million a year, just to make sure that we're able to do the research, have high fidelity data, be compliant with the trial, and be able to report data in an accurate fashion. I'll skip this slide because I've mentioned this. So now what I wanted to do is just mention some of the opportunities for collaboration in some cardiovascular areas. So one area that one of our investigators, Dr. Adrian Campbell Washburn, has been involved in has been the development of low-field MRI for cardiopulmonary imaging. So the NHLBI did some really pioneering work in CMR for the last 25 years. And the field, sort of everything was moving up in magnetic strength. And I saw the imaging program that you have here, which is really quite impressive. One of the things that our physicist about 5 or 6 years ago became interested in was this concept of, could you use low field MRI imaging and get the same kind of quality images that you would get from a very high field magnet, and do that through innovative programming of pulse sequences. So Dr. Campbell's group has been basically pioneering low-field MRI. This was a collaboration that was done with Siemens. So the NIH has the patent on the technology, but it's worked very closely with the Siemens folks. And the way that this was developed was we had a 1.5 T magnet that the Siemens team came out and turned down to a 0.5 Tesla magnet, and then that's where all the programming of new pulse sequences was done to try to optimize the imaging technology. So this is the prototype system that was developed and using contemporary hardware, and then modifying all the different computational methods. And this is just showing some examples of what you can see with the low field imaging platform, which can be utilized for more than just cardiac imaging, pretty much any imaging system. But the nice thing about this technology is that it's being developed not only for heart and lung, but also for things like the gastrointestinal imaging and looking at motility, as well as neurologic and other uses, including iron deposition in the liver in patients that have thalassemia. So why use low-field MRI? There's some significant advantages to this. The first is the cost can be substantially lower because of less expense related to the overall system, installation and maintenance of the system. They're much lighter. They need less shielding. They need less helium. And they can be installed in new environments outside of the type of environment that typically you would utilize in a radiology department. There's also the opportunity to try to reduce image distortion, and these can be better for patients that have any types of implants that would be problematic with the MRI. The other advantage is, because you're using low field, is that you have less heating of tissues and devices. And that means that you can potentially use low field for guiding catheter types of procedures. And then, as I mentioned before, it can also enable new clinical functionality. of looking at things like the lung and bowel and airway dynamics and MRI-guided procedures. So these are just examples of improvements in the technology with time using low field types of imaging. We have patients with all kinds of different diseases that we study in the NIH. One population that we have is patients with LAM or lymphangioliomatosis, which is characterized by cysts in the lungs, and this is just showing the kind of images that you can see with low field. We also did low field imaging on patients with COVID, in COVID pneumonia, and I'm not going to show you that data today, but we're able to see, almost pathognomonic signatures using low field MRI for patients that had COVID type of pneumonitis. Advantages of using MRI for pulmonary imaging is that it's free of ionizing radiation. And this is just showing comparisons of a clinical 1.5T MRI versus the prototype, showing very good ability to use an MRI to image the lung. And then these are just examples of low field in healthy volunteers with lung images showing normal looking lungs, and then patients with LAM, with cavitary lesions, as well as the ability to screen patients having small pulmonary nodules as well. So, and then more comprehensive pulmonary exams can be performed. You can do regional pulmonary perfusion. You can use 100% oxygen as a way to, as an enhancing agent for lighting up the lung space and alveoli, and also use this as a platform to gain more information related to the overall function and physiology of lung tissue. So I think that this technology is very much in its infancy, but we're very excited about partnering potentially with Tanam Hospital if you'd have interest in exploring the capability of a low field MRI system for all the reasons that I listed before in terms of advantages. This is just more application showing cardiac imaging with low field. And the other thing is, because you don't generate heat with these with the low field, you can do catheter directed types of procedures. I'm leaving these images on for the cardiologists in the room that use the CMR, just so you can look and see. But I think that usually when people see the resolution that you get on the 0.5 compared to the 1.5, in most cases they're pretty impressed that you can see this kind of detail with such low field. And then this is work that's being done now to use MRI directed procedures, right-sided heart cath and left-sided heart cath, because you can use catheters now that you would not be able to use in a 1.5T because they would heat, that don't heat up in the low field system. So this allows to use MRI guidance for complex procedures. So this went very quickly from a research platform to Siemens producing commercially available systems. So this system that's called the FreeMax is a 0.5T magnet, and this is just comparing to the 1.5T era, and then some of the difference, weight being significantly smaller, being able to fit it through hallways and doors, and having a much smaller footprint, and not needing to use anywhere near as much helium. And then this is the FreeStar system, which is even lower cost. So if you're interested in low field MRI, please let me know, because Dr. Washburn would be very interested to collaborate with investigators here. The last thing I want to mention is Dr. Tiffany Powell-Wiley, who does research in health disparities and looking at social determinants of cardiovascular risk. And she prepared these slides for me and has an interest with working with Miley Wynn to potentially collaborate on research looking at environmental and behavioral determinants of cardiovascular risk. And this is data that shows that there's been a shift towards a greater amount of non-communicable diseases being associated with mortality in Vietnam over the last several decades. So this is all information I'm sure you're all aware of, so less likely a chance of dying from infectious causes and more death from non-infectious causes. There's been, over the last couple of decades in Vietnam, increasing rates of obesity, physical inactivity, diabetes, hypertension, hyperlipidemia. So there is a need to try to understand what the effects of social determinants are on cardiovascular health, and this could be a very interesting area to pursue in collaboration with Dr. Powell-Wiley's group. She's been focused on looking at different environmental determinants in cardiovascular risk, including looking at things like neighborhoods and eating habits, stress-related cardiovascular risk, as well as crime rates and the association of crime rates in communities with cardiovascular risk. So she has a whole team that works in different neighborhoods, particularly underserved neighborhoods, where patients come in, they undergo a questionnaire looking at all kinds of social determinants of health. They get blood samples that are collected, they'll get imaging studies that are done, and then they'll be followed long-term to try to see if there's any particular factor that may be associated with them developing cardiovascular risk. So there's a community project now in Southeast DC, which is looking at whether you can identify risk factors in these patients and then come back with tools to try to intervene what that risk is, including setting up educational programs and trying to set up exercise programs targeting physical activity in these patients, and then trying to figure out a way, how do you get adverse social conditions to get under the skin and lead to cardiovascular disease. So that's a big focus of her group, and potential areas that her and I discussed to evaluate and improve cardiovascular health in Vietnam would be looking at urbanization, environmental factors such as social determinants of cardiovascular health, looking at cardiovascular risk factors, but also cardiovascular health behaviors such as physical inactivity, diet, sedentary behavior, smoking, sleep, and then trying to come up with a community asset mapping tool for resources to improve cardiovascular health, including engaging with the community and with stakeholders to try to develop programs to specifically address ways to overcome whatever risk factor is identified. So this is her her team, and then this is Dr. Miley Wynn, who worked with Dr. Vinh here at Tam An Hospital, and she's very interested in pursuing this kind of research in collaboration with doctors here, particularly interested in looking at urbanization and how urbanization can have an adverse impact in terms of risk in patients, and what exactly is contributing to that increased risk, and what interventions can be utilized to try to decrease those risk factors. So that's all I have for today. I just wanted to say that we have also fellowship training opportunities that would be available at NHLBI. So if there's staff here that would be interested in coming to the National Heart, Lung, and Blood Institute and being exposed to some of the research that we do or some of the technology that we have, we would love to develop that kind of collaborative partnership. And as I said before, we have branches that are focused on pulmonary medicine, cardiology, oncology, and hematology. When I was at NIHBT, we've had meetings to discuss the possibility of setting up a CAR T-cell program there, and maybe even that could be possible at BTH Hospital as well. So we're very interested in expanding capacity of hospitals in Vietnam to participate in cutting-edge research modalities. I would love to be able to have some type of a research hub that would be at Tan Am Hospital with research staff so that we could conduct multi-center studies, maybe 2-center or 3-center studies in different areas, depending on what folks' interest would be here, the patient population you would be serving, and different types of research exploring into NIH. So that's something, I consider this visit the first of hopefully many and the beginning of hopefully some fruitful collaborations in the future. But, just as an example, there may be drugs that are very expensive that would be prohibitively expensive to utilize in Vietnam in the context of a research trial. Those drugs could become available to patients. Some of these tyrosine kinase inhibitors for patients with solid tumors, hematologic malignancies could be utilized in a patient population in the context of research, and that would make a particular technology a medical therapeutic that wouldn't be available to your patients, potentially available in the context of research. Last comment is this is a picture that we took last night, and just want to thank everybody for the time that they spent with me, and particularly Dr. Vin, and I have had a very enjoyable tour this morning. I've been this new hospital and with all the staff that are here. So Vietnamese patients are truly, truly fortunate to have you all. So I would love to be able to work in the future more closely with your group in the context of setting up some research collaborations. So I'll stop there and thank you for your attention.
Thanks, Dr. Child. We appreciate your talk today. I think that the audience don't have any question from the audience.
So I have a question for the audience. So what was your thoughts on the low field MRI from the images? Any thoughts?
Hi, Dr. Hai. You talk in the microphone for the online.
Some young doctor to your center, to your institute, to see and to learn from the low field MRI for cardiac. And here is, and also in some article in the newspaper, we realized that mostly we do with the cardiac MRI in the low field is the cine image. And we just concerned about the quality of image and like the tissue characteristic with T1, T2, the mapping, and also the legged and diffuse fibrosis that we may see in the patient after chemotherapy. And maybe in the future we hope that we will learn more from you and your colleagues. Yes.
Yeah,
Thank
and you know, the way that she's doing the research is she's got the low field MRI next to the 1.5 Tesla, and they bring patients in with different diseases and are comparing, you know, patients that have myocarditis, viral myocarditis, for instance, patients with amyloid and different things like that, and are comparing the different technologies to try to you know, have that low field have as good a capability as possible.
I just wonder if is it a two machine or just one machine of 1.5 Tesla and then ran down to
Yeah. So it's
0.6?
two machines. So the original prototype machine was a 1.5 that was ramped down, and then once they got the sequences that were good enough, then Siemens went and made the machine commercially. So now we have that commercial machine at NIH, but we have it so that we can modify it and change it. And so we have that machine sitting there, and then we have the conventional 1.5T down the hall. So the patients get imaged in the two different machines, and then they get compared to each other.
Thank you so much.
Thank you. Yeah, and it's a, you know, it's a technology that's being developed. But I think that, you know, particularly for low income, moderate income nations where, you know, magnets are too expensive, it offers the possibility of getting a tremendous amount of information for a low price and being able to image multiple different organ systems. So that's the place that I'm thinking about, you know, that trying to develop these things in the context of expanding capacity in hospitals that would never have access to. I mean, your hospital has multiple magnets, but, you know, a lot of hospitals don't have that kind of access. So we have some collaborators in Kingston, Jamaica, and, you know, they're excited because they just got their first CT scanner. You know, so, but we're thinking about maybe sending a low field MRI down there to do research on their different populations. They have a big thalassemia population, sickle cell population, and exploring the potential there. Thank you. Yeah.
I have one question would like to ask Dr. Hạnh and Dr. Child. In the United States, you study about the MRI 0.5, while our hospital would like to buy 3 Tesla. I do not understand.
So I'm not a cardiac imaging person, but I can tell you, we have a 3T magnet.
Yeah.
And they decided to get rid of the 3T magnet. So, you know, I don't know, there was a lot of money that was spent on that 3T, but then they decided they didn't need it. So they moved away, they were going up in strength, and then, you know, I don't, what I was told was they didn't find advantages in the 3T. So now they're going in the opposite direction.
You know, at our general director, the big boss of a hospital, he just said to me that next month, maybe they will buy another 3 Tesla. And I think that I will translate something you talk to our big boss. It is better to wait for 0.5. That's right. Hi, what do you say?
Professor, to me, I think we may have mankind of machine like a range machine from 0.5 to 3, and maybe in the future 7T. And then I think with 7T, it is said that it like of tissue. That means with 7T, maybe we don't need gadolinium anymore because the resolution, the tissue characteristic with the 7 is so so good that we don't need gadolinium.
Yeah.
Yeah. In the study it said that, and I think when I see some picture here, some image here with the 1.5T, I have to say that maybe it is enough for us to do the like volumetric and function of LV and RV, but it's not really beautiful like 3T or 1.5T, and I'm still concerned about the quality. Is it good enough for tissue characteristic like T1, T2 map you show in here, or gas and diffuse fibrosis, etc.? Because up to now, 0.55 still not approved to do the cardiac MRI. We just have like the preliminary data on it, and I hope that in future maybe we can apply to some kind of patient like the patient with chemotherapy. We have to follow the LV function, RV function, and it is repeat like 3 months ago, and the is quite better than echocardiography. Like the variability between two times to measure the LV, EF is around 2.5 to 7% with CMR, but with echo it's around 9 to 19%. Yes. So the reproducibility of MRI, CMR is quite better compared to echo. And we see the cut-off to diagnose the toxicity myocardium after chemotherapy is 10% reduce of LVEF. So can we trust the result of LVEF by echo? It's a big question. I think so. Thank you.
Okay, any question? Dr. Nghi, do you have any question?
Yeah, I just want to ask in the low field MRI, do you have the information that is useful for the cancer patient? Because actually in our practice, sometimes we have the patient treat, but they have a kidney problem. So for evaluation, it's difficult to use the CT scan with contrast injection.
Yeah.
So do you have any information about the low field MRI for the lung tumor or the lymph node, something, etc.?
So I showed you some of the lung imaging that was being done for finding small nodules. So this investigator, what she's doing is she's working with different groups that have studied different diseases. One of the groups is with doctors in the National Cancer Institute, where they're doing imaging in patients that are receiving tyrosine kinase inhibitors that inhibit angiogenesis and can lead to ischemic changes in the tumors, and seeing whether or not using low field MRI can give you information about the actual physiology of what's occurring in that tumor in the context of these targeted therapeutics that maybe you would not be able to tell with CT scan. So there are comparisons that are going on with serial imaging of lung tumors using standard CT versus low field MRI to see, one, can you just see in terms of the size and measurements and RECIST criteria, but also can you see things that have to do with perfusion in the tumor that you can't see with CT, that would give you some advantage to maybe where you can look and say, by CT the tumor didn't shrink, by CMR it didn't, by low field MRI it didn't shrink, but you can see that there's ischemia now occurring and you can predict that it will shrink, or there is going to be a biologic effect that will lead to inhibition of tumor growth and will lead to stable disease. So that is an area that is being explored in different subtypes of tumor. We'll need a little while to be able to get that information. But the nice thing about the lung stuff is that it doesn't involve ionizing radiation. And in transplant patients that I take care of, these patients, it's not uncommon for them to get, between 10 and 20 CT scans over time because they develop, pulmonary complications, bronchiolitis obliterans, COP. They may develop fungal lesions where you're having to follow them and new therapeutics and see whether they're working or not. So the idea that we can not have them exposed to any ionizing radiation, I think potentially is going to be advantageous to them. In the field of transplant, the risk of secondary malignancy after about 15 years is in the range of about 10%. And we think, a lot of that has to do with all the ionizing radiation that they're exposed to. So particularly younger patients. So I think there's that advantage. And then, whether or not you would be able to stage tumors that normally you would need contrast for, like hilar nodes, mediastinal nodes and stuff, that's all stuff that's being explored in head-to-head comparison. So we'll need a little bit more time, but I think that there's tremendous excitement about the ability to image the lungs, and now there's also, comparison of liver lesions, CT versus MR. As you know, many times MR gives you better detail in liver lesions compared to CT, and whether or not you can see the same improved in resolution with low-field MRI compared to standard 1.5 is also being explored. So for the field of oncology, I think that, this could be a very valuable tool to avoid all the radiation that you get with frequent CTs. Even though CTs now are using much lower, radiation exposure amounts, it's still not zero.
And the second question is about the T-CAR cell and the NK cell in the, first of all, with the T-CAR cell in RCC. In RCC, we still confront a lot of difficulty for treatment. And just want to know, in your research for T-CAR cell in RCC, is that just only take place in the US, or do you have the site, other sites over the world?
Yeah. So what we're doing is only in the NIH. That's it, the only place. And it's very much at the early stage, proof of concept. T-Cure has licensed this, and they're planning on doing a big study in China. The restricting allele that this T-cell receptor requires is HLA-A11, and A11 is only present in about 15% of Caucasians, but it's present in a very high percentage of Asians. In the range of 40 to 50%. So that's why the Chinese got very interested in this T-cell receptor, and I believe why that company licensed the T-cell receptor. We also have antibodies that target surface expressed parts of the virus that are not presented in the context of MHC class 1 molecules. So it would be the same thing as like CD19 on a B cell. This would be the endogenous retroviral, a piece of the envelope that's expressed on the surface. And we have antibodies to that envelope, and we have now made CAR T cells that have no MHC restriction at all. So we can use them, with virtually every patient with clear cell renal cell carcinoma. So that technology I'm really super excited about, but that's not going to be in the clinic probably for about another 3 to 5 years because we have to prove that those antibodies only bind that endogenous retrovirus, that there's no off-target binding, and then we'll have to move that from in vitro to mouse experiments and then ultimately into humans. So that whole process takes a bit of time. But, when we get that up and running, that absolutely would be something, that we would be open to collaborating with, doing multi-center studies, 2 or 3, sites, if they had the cell cells. So a patient could undergo an apheresis, have the cell sent to us, we could put the T-cell receptor in or the CAR, freeze them, and then ship them back for infusion. That would be the way that they would be exportable.
Because I just want to know if, according to the law, is permitted, if you can accept the foreigner's patient. Please let us know, even if you don't.
Yeah, you mean refer to us?
Yeah.
Absolutely, 100%. So, all the patient has to do is be able to pay for the air trip to the U.S. If they can pay for the air trip to the U.S., we will put them on the study, treat them for free, and we will give them money for housing and lodging for the entire time they're there. And we'll pay